Okay, we are recording. Hello, everybody. Welcome to this very exciting event. This is the premiere episode of Ask Dr. Death. It is February 16th, 2020. I am Dr. Terri Daniel, and we're here with my friend, Dr. Karen Wyatt. And that's Karen, and we're so excited to be working together, and we're going to just jump right in because we have so much stuff to talk about. But let's just start briefly with introductions. So Karen, you start and tell us about your work and how you came to this moment.
Okay. Well, I am a retired now hospice doctor. I found my way into hospice medicine after my dad died by suicide when I was a very young doctor. And I started working in hospice to help me deal with my grief and fell in love with hospice and stayed there ever since. So became a full-time hospice medical director, making home visits to patients. And then I left my medical practice about 10 years ago to start writing books and blogs and doing podcasts and interviews, recognizing that we needed a lot more education about death and dying in our society. So that's what I've been doing for the last 10 years. I have a podcast. Oops.
Okay, somebody needs to mute themselves. Okay, we got it.
So, yeah, I have a podcast called End of Life University podcast on iTunes. And I do a lot of speaking and teaching and workshops and classes, things like that. So, and I'm really excited to be here. This will be really fun.
And what website can people find you at?
They can go to eoluniversity.com, and that from there they can find all my blogs and my podcast and courses and everything from that URL, eoluniversity.com.
Perfect. And we also have an Ask Dr. Death website, which is askdoctordeath.com, and it's doctor spelled out, because if it's Dr. DR, that would be Jack Kevorkian.
Yeah, I was going to say, I don't want to be associated in any way with Jack Kevorkian. Good. I'm glad we had a disclaimer about that. Okay.
Yeah, exactly. And that's why I did it so it's spelled out. And my PR people said, do you want to just be called Dr. Death? And I'm like, no. Yeah. Okay, thank you so much, Karen. You have a lot of fans here. A lot of people have emailed and said, we're so excited to see Karen because we've been following her for a long time and we love her. And I love you too.
Oh, so it's mutual, Terry.
So I'm Dr. Terri Daniel, and I've only had doctor in front of my name for less than a year. I'm not a medical doctor. I am, my doctorate is in pastoral care and counseling. So probably as we go forward with this podcast, I will probably address most of the counseling kind of questions and the grief recovery kind of questions. And Karen will probably talk more about the hospice and death related questions, but we can certainly cross over on all of that. And I am the founder of the Afterlife Conference, afterlifeconference.com, which is how I met Karen. Mm-hmm. She's spoken at the conference at least twice, maybe 3 times.
3 or 4 times.
3 or 4 maybe. So hopefully you guys will all go check out afterlifeconference.com. And the reason we started this is it's obvious, because these are conversations that need to happen. And today, and I think maybe every month, we're going to start with little interesting tidbits of information about death that you may not know about. So we're going to start with like a little piece of research, and then we'll go right into the questions. And so this one I pulled together today from this book called Attitudes Toward Death from the Middle Ages to Present by a French researcher named Philippe Aries. I know this book because it's recommended by the Association of Death Education and Counseling, ADEC, ADEC.org, in preparation for their test that they give you to become a certified thanatologist. And he did this amazing research. I'm just going to throw some of this stuff out there at you. Back starting probably around the 12th century, people died according to what he calls tamed death. Death was completely accepted. He calls it a prevailing knowledge and acceptance. And they know this by looking at art and literature. So if you look at art and literature for hundreds of years, you see pictures of the old man on his deathbed surrounded by his family, and then the priest. And what happened in those days is people would just know that they were dying. If they were sick, there weren't interventions for cancer and strokes and things like that. People just said, okay, I'm done, I'm dying. They'd go to bed, they'd call the family, they'd call the priest. And that's how it was done for hundreds of years. So the dying person created their own trajectory of dying. They kind of mapped it out the way they wanted it to. Nobody did it for them. The younger, stronger males in the family would be out in the barn building the coffin, but they didn't even really have coffins in those days. They just wrapped you in a sack and threw you in the ground. But there were actually stages of accepting your death, which have nothing to do with Elizabeth Kubler-Ross and her stages. This is really interesting. So the first stage was acknowledging when you realize you're going to die. You acknowledge your attachments to the world, your attachments to the people around you, the people you love, your accomplishments, the meaning of life, kind of like a life review. And in those days, they would call it laying down your weapons or your tools of your trade and giving things away in some cultures. And then you would go to your bed and you would lie there in the funerary posture of art and sculpture, you know, lying there like this. And that was stage one. And stage two was acknowledging your sadness for leaving this world and missing the people that you love. And you would call the family together to say your goodbyes and say your lamentations and pardoning, forgiveness, blessings, all of that stuff. This was very common in those days. And then you went to the third stage, which was, now that we've kind of taken care of everything in earthly life, now we're going to stop focusing on earth and we're going to start focusing on the divine. We're going to start thinking about God. And that's when the priest comes. And in those days, again, we're only talking about Western society, the priest would offer confession and absolution and last rites. And this was how people have been dying in the West for millennia. Very different than the way we do it now. They also had at the time peaceful coexistence between the living and the dead. Some of you may know about the very famous first hospice in France, and I'm going to try to pronounce this in French, so pardon my French, but the Hospice de Beaune, the hospice in Beaune, France, started in 1400, and it was this giant cathedral, and they would have people dying on one side of the room and people giving birth on the other side of the room, and children playing and musicians strolling and mothers nursing babies, and it was all in one room. And that's how it was done back then. So does anybody want to take a guess on what might have made that change? All right, well, what happened was, and I just back up for a minute, going back to ancient times, before this, people were actually afraid of death, and they had taboos about, you know, eating anywhere near a dead person or having a dead person near you. As you know, some indigenous cultures, you know, will not speak the name of the dead, which is actually not really healthy for grieving. But then the church came into power. And so what happened there is everybody started moving death into the churchyard, and they started to believe that if we buried people in the churchyard, they would be protected from hell and demons. And so that church gradually took over death care and became the keeper of death, where it still pretty much is today. I'm sort of speeding through this. And now fast forward, so what happened was the churchyards eventually got too crowded, and they didn't dig very deep graves, and on really rainy days, bones would float up to the surface and decomposing body parts, and it smelled bad, and it was just horrible. And so they had to stop doing that. And one of the problems they had was that grave robbers would come and dig up the graves and take the cadavers to use in medical schools. They started doing this in ancient Greece. This has been going on for a long time. And they would leave quite a mess in the graveyard. And there was just decomposed stuff everywhere. point being that death was all around. You would go to church and you would see bones and you would see death. And it was very, very acceptable. And in places where there wasn't good ground suitable for burial, they would bury somebody for 5 years and allow decomposition to occur. And then after 5 years, they would be exhumed, and now you would have bones. And they would take the bones and put them into an ossuary or a charnel house, if you've ever heard of that. And that's where the bones were stored. And now they could use that plot of land for the next generation of dying people. So they recycled the grave plots. And around the 19th century, it became fashionable to be emotional. This had also to do with the church, with a lot of fear and horror of resurrection. And people started crying openly and being very, very verbal and emotional about it. And that was kind of the beginning of pushing death away from us and being afraid of it. That happened in the 19th century. And moving forward quickly, we're now in a stage that he calls forbidden death. And that's around the 1930s, people started to die in hospitals. And we had funeral homes, and we didn't bury people on our own land anymore because we weren't on our own land anymore. We were getting jobs in the cities, working in factories. And I guess we just didn't have time, or we didn't have land to bury people. So that brings us up to where we are today with death in what Philippe Arias calls hidden death. So I will send you guys a link to that book if you're interested in it. So that was my big long spiel. I'm going to take a breath. Karen, you want to jump in with something? What do you think about all that?
Yeah, I was going to say that a lot of those changes around the turn of the 20th century, so about 1900, which is when funeral parlors got started and the really common use of embalming. That's also when medicine started making a lot of advances. There were a lot more hospitals sprung up. Doctors began studying in different specialties. And not too long after that, I mean, we developed better anesthesia and more surgeries. Then antibiotics came on the scene. And so it was all kind of a perfect storm. We had the funeral industry on the one hand to remove the dead bodies from our sight and vision, and the medical industry removing the dying patients from our sight by keeping them in the hospital. And so all of it was part of modern society, what we thought of as being modern. And the people at that time really wanted to embrace these new trends because they wanted to be seen as modern and keep up with these modern trends. And it's ironic that now, 100 and some years later, 120 years later, all we want to do is go backwards if we can, and go back and regain some of those old traditions that brought so much value and meaning and richness to the dying process.
Yeah, I was talking to somebody in a podcast the other day in a grief workshop about in Native American culture and in others that I can't think of offhand, you're not allowed to speak the name of the dead. And now we know with contemporary grief theory that part of healing from grief is to say their names and remember them and have altars to them and around the family Christmas dinner table, that we want to remember them and say their names. And gosh, so much has changed. So antibiotics and surgery, that was the thing.
And ever advancing technology, which we're dealing with right now, and our ability to prolong the dying process without really restoring quality of life to people, but we can keep people alive far, far longer than we really should. And it's because we haven't come to terms with how do we as a culture and a society really feel about death, and can we embrace it, and can we allow it to be a natural process?
And so we're not prolonging life, we're prolonging the dying process.
The dying process, exactly. In many, I would say most cases, we're actually dragging out the dying process with many of the interventions that we do and the extreme measures that we do for people.
So one of the things I wanted to talk about in another podcast, but this might be a good place for it, is doctors and their training for dealing with death. I want to do another podcast, Karen, with you and my young nephew, who's 35 and is an ER doctor. And you're in what different generation than him. And he had no training in end-of-life care in medical school, and you didn't either, right? So talk about that a little bit. What do doctors learn, if anything?
Well, you know, our first exposure to death is dissecting a cadaver in gross anatomy lab, which starts on day one of medical school. So you walk in, you know, like early 20-something, 22-year-olds who's never seen anyone die before, and you're given a cadaver that you have to dissect. And so that tends to be somewhat traumatic in the beginning. They do things to try to make it less traumatic by keeping their face and hands wrapped in gauze so that you can't see them and you're only working on a small part of the body at a time. But that's our main experience with the dead, is spending an entire semester in gross anatomy lab with a cadaver. Other than that, I felt that we were really sheltered in some ways from death, that they really kind of, our attendings and the residents we worked with never talked to us about the patients who were dying. They actually, once we knew a patient was definitely going to die, we stopped rounding on them. We didn't go visit them anymore. There was no more need to even discuss that patient. And we weren't assigned dying patients because they didn't feel it was a good learning experience. They wanted to give us patients who would recover. And so that was part of it. We had no exposure, no experience, no training, and no one talked about it. And so even when we did experience a death, like in a code when we were doing CPR on a patient that didn't work, didn't resuscitate the patient, and they died under our hands while we were doing CPR, no one was there to talk about the fact that this person was alive. Now they're dead. How do you feel about that? You know, no one talked to us about it at all. And I mentioned to you a story of trying to resuscitate a 16-year-old girl in the emergency room who'd been in a terrible automobile accident. We tried everything to try to save her because of her young age. And she ended up dying, and I was just a medical student. That's probably the first death I ever observed. And I was shocked and completely devastated that we couldn't save her, because that's why I went to medical school, so that we could save people like her. It was crushing to me that we couldn't save her life, and that when they finally decided to call the code, everyone just walked away and walked out of the room. And I stood there with all these emotions and trying to figure out how do I put all this together? How am I supposed to feel about this? But there wasn't a single person I could talk to, not even a nurse, no chaplain, no social worker was there, no one. Everyone went about their jobs. And I was left to process that all by myself. And I mentioned to you, Terri, that night when I got home, probably at midnight after a whole day of working on my feet in the ER, when I went to undress, I found that the bottoms of my shoes were stuck to my feet inside, and they were filled with the blood of that young girl that had dripped into my feet during that code while we were trying to save her life. And I just completely fell apart then. As I took my shoes off and saw her blood there, I just sobbed and sobbed. And so that was my first experience of dealing with grief and loss and guilt as a doctor, all by myself.
Wow. I just want to interrupt for a minute and say that if there are a couple of people whose microphones are on, and I can hear you making noise. So can you just make sure that your microphone is muted? Go onto your little screen that you're looking. There you go. Somebody, I think, just did that. I'm not sure, but just look on your little screen where you see your name and make sure that you unmute that microphone. Karen, that's amazing. And so from my perspective as a grief counselor, the fact that they covered the cadaver's face, I find really bothersome, because I can see that it would depersonalize it and make it less emotional for a new medical student, but that's exactly the problem as well, because it doesn't show you that this was a person.
Yeah. Yeah, and the last part of the body that you work on is the head and face. So that doesn't get unwrapped until the very end of the semester. And, but by then you're kind of used to this body, and you've kind of gotten to know this person somewhat that you're working with. Most of the students gave their cadavers a name. We weren't told a name, but we gave them a name, and that actually helped to humanize it a little bit. Yeah. But once again, there was no one there to talk us through it. I have heard that nowadays they actually have memorial services at the end of that gross anatomy lab, and the students all come, and even the families of some of the body donors will come, and they kind of give their thanks to those people who donated their bodies for medical science, which that sounds at least like some kind of closure or resolution to the whole thing.
I love that. And somebody just posted here about being a full body donor. I'm a full body donor. I love the idea that they invite the family, because body donation is really hard for a family.
Yeah. And, I will say it's important. It's very important, because there's so many things that we learned from that practice, and bodies are used for all sorts of things, all sorts of training, and for surgeons to practice new surgical techniques that honestly could not be learned without those bodies. So I'm so grateful, and I honor everyone who decides to do that, to either to be an organ donor or a whole body donor.
How does a person become an organ donor? I know you can put it on your DMV registration on your driver's license. Is there another way to do it?
That I think you have to have that designation, because once you die, in case no one else knows that you chose that, they need to be able to see documentation that you chose it. But you should tell everyone in your family and all your loved ones that's what you want. I know for whole body donation, you go sign up with a particular program that agrees to come and receive the body, and there are various companies that take care of that around the country.
And I imagine you could put it in your advance directive?
Yes, you could. It's important to make sure that someone else knows about it, though, because especially for organ donation, they have to handle the body a special way to preserve the organs at the time of death.
When my son died, he had a rare metabolic disorder, very rare, under-researched, and I donated his brain to the Maryland Brain Bank. And when they took his body out of the house in the body bag, and I just unzipped it and saw his little face and gave him a million kisses and said, I bless this brain that it can be used to help other people. And they're not allowed to tell you where the tissue goes for research, but they say that you can call whenever you want and ask them, and they sort of will tell you. So about 4 years later, I called, and they said that his brain tissue was donated to a study in the Netherlands. And it blew my mind how it felt to think that there was a piece of tissue of his still alive in a lab somewhere, because it's still kind of alive, right? And it was kind of like he was like in a science fiction movie. He was like reanimated. So it's a really, really beautiful thing to do. And since it's not the Middle Ages and nobody can rob bodies out of graves anymore like they used to, so it's really important to do organ donation. I'm glad we're talking about this. We could do a whole podcast on this.
I'm sure we will too.
Yes, we will. So, okay, let's jump into some of these questions, because you guys asked the greatest questions. Karen, let's start with that question we talked about yesterday. Somebody was talking about how their loved one was in hospice and felt that the hospice did not give the patient enough medication to kill their pain. Here's what it says. I hired hospice at home for my husband who was dying of pancreatic cancer. At the end, he was in terrible pain, screaming in pain, and hospice would not give him enough morphine and Ativan. What do you think is going on when something like that happens?
Well, I mean, that absolutely breaks my heart. That story is devastating to me as someone who worked for so many years in hospice, because the entire mission of hospice is to keep people comfortable at the end of life and to make sure that their pain and other symptoms are adequately treated. That's the number one mission of the hospice. And so I'm full of questions. I don't know what might have gone wrong there, because the one thing that everyone in hospice receives training in is symptom relief and pain management, to make sure that we know how to alleviate pain. I have heard stories over the last few years of certain for-profit hospices that were very disreputable, that didn't want to pay for medication, so they weren't giving patients enough pain medication. There have only been a few companies like that I'm aware of in the country, but they were brought up on charges because of inadequate pain management, for one thing. So what should happen is that the hospice should make sure that there is an adequate supply of morphine or any other, whatever medication is needed for pain should be in the house. The family members should all be trained how to administer it, because typically the hospice workers are not there. The nurse is not there at the moment the patient needs pain medication. So it's the family who has to respond. So I don't know what went wrong, if there wasn't enough medication there for the family to give, or they hadn't been trained to give the medication. But that is a horrible story, and it appalls me to think that happened. It should never be that way.
And one thing I would add to that, and this is not to put blame on anybody, but it's because the family is given control over the medication, a lot of family members aren't comfortable giving enough medication. I mean, we've heard this many times where, people will say, well, I kept giving my father morphine and then he died, and now I feel like I killed my father. So it's really difficult, because people have this misconception that you go to hospice, they give you morphine and they kill you. Mm-hmm. Which is completely not what happens at all. But because people are so uneducated and have so many misconceptions, that's what they think is happening. So they'll be given control of the morphine, but they won't give it because they think that's what it's for. Mm-hmm. And that's what's really heartbreaking, is the lack of understanding of how that works.
But see, that should also be the responsibility of the hospice staff. They should be educating the family, everyone there who's involved in giving the care. And even they should even know how to talk to outsiders or friends or visitors who might come, who may have questions about morphine. They should have been educated and should be empowered to know how to talk about morphine and how it works and why they're giving it and why it's important. And so that sounds like a failure of the hospice as well, if they didn't educate and empower the family. And it may take a lot of education and convincing to help the family see that they can give doses. But part of our whole process is learning how to titrate how much medication the patient receives to achieve relief of pain without snowing them or putting them under or making them unconscious. We try to find a balance between that if we can. Even if it doesn't work, and if a person is still in horrible pain, there is something called conscious sedation that can be used to alleviate the pain. There's no reason why someone should have to die in pain, because there's so many different options available. So there was a terrible failure there in some way or another that happened.
And back to what we were talking about earlier about the way things were in the Middle Ages, even though those people had so much acceptance of death and they would just go lay down in their bed and say, okay, I'm going to die now, they must have died in terrible pain.
Yeah. I don't know for sure if they had like opium available back then, which is the precursor to morphine. And so I don't know. I'm curious about that. I did read that back in the 1950s, before modern hospice was started, about 75% of cancer patients died in pain in the hospital because pain was very much undertreated then. Doctors were really afraid of using morphine or pain medications. And that's one of the things that inspired Cicely Saunders to start the first modern hospice in London, because she witnessed people dying in pain.
And meanwhile, people in China were smoking opium and passing out in their fields and having wars with England about it because it was everywhere. So we finally figured out what to do with it and make it useful. So another question, Karen, I'm hope I'm not putting an undue burden on you on a lot of this, but this medical stuff, you know, we've got the spiritual stuff and the grief stuff and the medical stuff, but I find the medical stuff really interesting. Another question that someone asked was, we hear all the time that people die from Alzheimer's, but how do you die from Alzheimer's? What's the cause of death?
So it can vary, but Alzheimer's causes just this gradual disintegration of cells of the brain and the connections between cells in the brain. So there's this gradual progressive deterioration of how the brain functions over time. The majority of Alzheimer's patients actually end up dying of infection, which really comes about kind of secondary to the Alzheimer's because patients lose the ability to swallow well. So they may aspirate food into their lungs and get pneumonia. They also become immobile and they can get urinary tract infections and skin infections from bed sores. So they might become septic from those infections and die from the infection. And then it depends if they have other underlying disease like heart disease, they might die of heart attacks or of blood clots that form and go to the lungs or heart. Some even have strokes, but infection is the most common. And then also some Alzheimer's patients actually are very healthy other than the Alzheimer's and the effect on the brain. And so those may be some that live a much longer time because there is not underlying disease in the body that could take their life earlier. They may end up dying simply from what we might call failure to thrive, not being able to eat or drink adequately. So they just lose weight and become completely cachectic or become dehydrated unless somebody puts in a feeding tube or gives them IV fluid, which would, again, prolong the dying process if they did receive that kind of intervention.
So the language is so important, isn't it? I mean, we call it prolong the dying process, where lay people would call it prolonging life.
Yeah, and I think that that's a big misconception in our society that it's important for us to deal with too, because there are people who think, why would we not want to prolong life? Why would we not want someone to live as long as possible if they could? Why wouldn't we keep them alive if we could? But if you view it that they are actually in this slow progression toward death, and we're slowing it down even more. We're making the process take even longer and adding even more suffering by trying to keep like any little shred of their physical body alive that we can.
Okay, so we're getting some things in chat. So I'm going to switch from medical speak to grief speak now.
Okay.
And somebody posted about going back to being a full body donor. She's a full body donor, and they do have a service when the medical establishment is finished with the cadavers. She's worried that service won't happen for a couple of years, and will that delay her son's grieving process? And so my answer to that is hopefully your son isn't going to wait until the hospital is done with your body to have a service for your memorial. Hopefully your son will have his own ceremony and the family will have something. So the idea of waiting until the body is finished being used is absolutely not necessary. You're not in that body. You had not been in that body since the moment your brain went flatlined. And that's when the service and the memorial and the grieving starts, not when the body is disintegrated. Because, you know, if we wait for that, we'd be waiting years and years until people decompose. So please tell your son that he can have any kind of ceremony he wants, any time he wants, including when you're still alive. A lot of the people that I work with who are dying, I encourage them to create their own celebration of life while they are here with their family members around them. And Karen, that reminds me of our friend Alia in Colorado.
Mhm.
This was a woman that I've known for many, many years who got MS when she was in her early 40s. And as she was getting closer to death, she was completely paralyzed. She was able to eat and speak. I don't know exactly medically what it was. Karen could speak to that, but Karen went to see her in Colorado, and so did I. This woman was extraordinary. She not only planned her cremation, but her funeral service with all her friends there. And about a year before she died, I went to her house and did a grief ceremony for her and her friends and her family while she was right there in the room with us. To me, she died about 2 years ago. She is the epitome of conscious dying. She is one of my great heroes. And she has a blog called Meet Me by the River. And you can Google that. I will send you a link. Karen, anything you want to say about Alia?
No, but I like, as you said, she was a remarkable person. I was just amazed at her undaunted spirit and her joyfulness and loving life in spite of this awful disease that she was living with.
She was pretty amazing. So here's another question. Somebody asked today, how can someone, a psychotherapist, get the necessary credentials to, I'm really jumping into another realm here, to work with grief? I don't have it right in front of me. It should be right here someplace. I don't know. Oh, wow. Oh, what kind of supplemental education can you recommend for psychotherapists who want grief training in order to up their skills? The reason I want to bring in this question is because so many of you listeners are professionals who are working in the field, and I get this question all the time. If you are a psychotherapist and you're already licensed, you're way ahead of the game. You can pretty much do anything you want. But if you're just starting out and you want some credentials that will get your foot in the door of a hospital or a hospice, and even if you are a licensed therapist, the absolute gold standard, top of the line credential right now, the only one that exists in this field, is the certification in thanatology from the Association of Death Education and Counseling. It's ADEC, adec.org. They give you a test. They do a big, it's online, it's a test, 150 multiple choice questions. They offer it every November. They send you incredible study materials. I took the test in 2015. I didn't even have a master's degree at the time. I only had a bachelor's, and they let me do it. And I now have CT, Certified Thanatologist, after my name. And it has opened many, many doors for me. People recognize this designation in the death and dying field. So if anybody's interested in getting some alphabet soup after your name without going back to school and going into debt for $100,000, this is an affordable and very manageable way to do it. So I really want to promote that as much as I can. So that's adec.org. Just click on the link to their thanatology certification. And let's look at some other questions here. Oh, I love this one. This is a metaphysical question. What would your recommendations be in terms of not moving the body and giving it time before cremation and burial? So this is, in my opinion, more of a, in many cases, a religious thing. So I worked with a Buddhist family once, and the man died at home, and I did not know their tradition. Their tradition was that you do not touch the body for 3 days because it disturbs the flight of the soul. So I come in there as a hospice professional, and the first thing I do is walk up to the body and touch it. And I touch his hand and I touch his face, and I do little ceremonies. And the wife just freaked out when I did that. She goes, "No, you're not supposed to touch him. It's going to stop his soul." So I was incredibly embarrassed, and I learned a lot. I think this has to do with people's individual belief systems. I don't think any of us can speak with authority about exactly what the soul needs immediately following departure from the body. A lot of us have intuited this. We've heard accounts from mediums. My personal opinion is that the soul wants to get the hell out of there as quickly as possible. But that's just my opinion. Karen, do you have any thoughts on that? What have you heard about that?
No, I haven't heard anything about that, but I could understand that even the family might need a little bit of time with the body, and that could be nice to have some time to have, if the person dies at home, to be in the, or even I guess in the hospital, if someone wanted to be in the hospital room with their loved one and be close to the body. I think that could be very sweet, but I don't believe that it makes a difference to the soul one way or the other. I think it could be for the sake of the family members who are there.
Yeah, I think the question is not so much about staying with the body as it is before you bury or cremate the body.
Oh, I
or
see.
move the body or touch the body. What
yeah.
I try to do is I believe in touching the body. It's just one of the I think that you should touch the body. I think that it helps people get the reality of the death. And I also believe that people should stay with the body as long as they want to. And certainly in hospices, they will let you do that. Depending on the temperature in the room, you can leave a body there for how long, Karen? 8 hours? More than that?
Yeah, probably for 8 hours. But fairly soon you'd want to get the body on dry ice if you were going to keep it like overnight or something. But
yeah, I think it's really important to stay with the body as long as you need to. And in some traditions, in the Jewish tradition, in the conservative Jewish tradition, they have a person whose job it is to stay with the body for the first 24 hours, even if the body's in the morgue. Somebody sits there for 24 hours. And I don't know what the metaphysical explanation is for that, but I would like to think that it has something to do with helping the soul ease its way out, even though I think that the soul just is like, whew, I'm out of here. But that's not always true. In the Buddhist tradition, we have the Tibetan Book of the Dead. And what they do when somebody dies in Tibet is the Buddhist priest comes to the house and essentially reads this book to the dead body, which gives it a roadmap of where it's going to go for the next 40 days. They call it the 40 days of Bardo. That's what the Tibetan Book of the Dead is. And it basically says to the soul, okay, you're traveling through this really weird realm right now and you're seeing all these demons and scary things. Pay no attention to those demons over there. Those are just your lifetimes of wounds and pain and projections that are just calling at you to be attached to them. But the whole idea here is don't be attached to them. So don't go over there where the demons are. Go over here where the light is. And it's directing the soul for this 40-day journey. And the Egyptian Book of the Dead has that too. So there are a lot of traditions that talk about that, but I don't think it requires a body in order to do that.
Mm-hmm. There's one question here. I've heard that Alzheimer's patients are partly in this world and the next, which I have long actually thought that myself when I have sat with Alzheimer's patients, kind of wondering about that, because I had some Alzheimer's, very end stage Alzheimer's patients in hospice who hadn't spoken for, one man hadn't spoken for over a year. And the week before he died, he began speaking in the night to his brother, and his wife would hear him speaking completely lucidly. She was totally able to understand every word he said, and he was talking to his brother who was in the room visiting him, which was really shocking because medically he should not have been able to speak, but he was conversing with his brother. So that always told me there's something going on here between two different worlds.
I always felt that about Alzheimer's too, is that, when they think they're back in World War II, they really are, because in the spiritual world, time is not linear. And so when you're in a metaphysical space of timelessness, all events are happening simultaneously. So when somebody with Alzheimer's thinks that he's, shooting the enemy in World War II, He really is. And it's basically a life review. We've all heard of life reviews that we have in near-death experiences. This is a life review that's happening before you actually die.
And it can last a long time, months and months,
Yeah.
years even. While we're talking about Alzheimer's, I wanted to make a recommendation of a book. It's by Dr. Judith London. She's a psychologist who works with Alzheimer's patients. And her book is called Connecting the Dots, Breakthroughs in Communication as Alzheimer's Advances. And it's an excellent book full of stories. She does this groundbreaking work with Alzheimer's patients, bringing them together in groups. They listen to music and eat ice cream together. And it's really beautiful. She tells a lot of stories of patients and how families have been able to stay connected with their loved ones with end-stage Alzheimer's by just understanding this process and what's happening. So anyway, Judith London, Connecting the Dots is the name of the book.
I typed it into the chat room so everyone
okay.
can see that. And there are some wonderful videos on YouTube also of Alzheimer's patients responding to music and other things. Somebody posted a question here. What are your beliefs about dying with dignity? You want to start that one, Karen?
Sure. I said the Death with Dignity movement and medical aid in dying. So I believe that it's very important that that it become legal everywhere and that patients have access to make that choice for themselves. It's my hope as a hospice doctor that not very many people will need to make that choice, that we will do such a good job of caring for people and helping them at the end of life that they won't need to make that choice to hasten their own death. But I am supportive of it and of the need for it because it's simply, some medical conditions that people are dying from, like MS for one and ALS for another. It's horrific to see the suffering that people have to go through, and to know that they could make a choice and choose how and when they die. I think it's essential that we have it be legal throughout our country.
And do you know where that stands now, and how many states it's legal?
Oh, I might be wrong about this. I think it's legal in 7 states now, but there are maybe 20 some other states where it's being considered. So I know it's, people are trying to get laws passed, and it's been challenging. It's been difficult because doctors are not always willing to support it. So they're not willing to write the prescriptions. And even in some states where it's legal. And so it's a work in progress trying to get that to advance, but I might be wrong. I'm guessing 7 states. I think, and also the District of Columbia, but I could be wrong, and I could look that up for the next
And we can easily research that.
Yeah.
I think, this is our first podcast, so I think we're all finding out that there's just so much stuff to talk about, and probably in future podcasts, we're going to have to put it into little compartments.
Yeah.
One thing I want to throw in as a question, and I talked to you about this, Karen, I've heard so many cases where doctors, we're back to the education of doctors now, will not give an order for hospice. Somebody that I know, he was in ICU, he was 90, he had congestive heart failure, he was on a ventilator, and his son went to his doctor and said, "Can we go to hospice?" And the doctor said, "I only prescribe hospice if they're 3 days away from death." And the son said, "Well, he's on a ventilator, so he's actually dead." And the doctor said, "No, because we can still keep him alive, so I'm not going to write an order for hospice." And he died in ICU.
Oh, that's the horrible mentality of doctors who've never been trained at all about death and dying, who don't really have an understanding about it, and who've totally embraced this old idea that our entire job is to save lives. That's why we're here. That's why we do what we do. And who don't connect death as part of life, as part of the cycle of life. They don't recognize death. They don't want anything to do with it. Some of those doctors, I believe, have some kind of issues of their own. Maybe they had a traumatic loss earlier in their lives. Maybe they have unhealed grief from something that happened, and they've just decided to completely shut themselves off from death, not talk about it or deal with it. Definitely they haven't been trained how to do it, or how to talk and think about helping someone at the end of life, and haven't had any exposure to hospice. So oh my gosh, that's a huge job. We have so much work cut out for us to try to change the behaviors of these doctors who are causing harm.
Yes.
By really their ignorance, but also their resistance. And I just think when someone's that resistance, something else might be going on. That person might have an inordinate fear of death, or their own grief, or maybe guilt about a patient who died in the past, and they can't bear the thought of going there.
I think that's exactly right on. And I think you might really have hit it on the head with, they lost a patient at some point in their early career. Maybe it was a child or something really terrible, and they vowed to never let anybody die again or something, or unresolved grief in their life. I was at a hospice and palliative care conference just this last October, and somebody was presenting their research on death anxiety in medical students. There's actually been a lot of research on this. I will try to remember to send everybody the link, but they found that the more time a student spent in medical school, the higher their death anxiety became, which I think is just fascinating. So, the process of being in medical school just makes you even more and more uncomfortable with death. I want to end on this one question. This is a grief question, and it's from one of our listeners. And she's talking about, she has a daughter with stage 4 breast cancer, metastasized to liver and bone. This daughter refuses to discuss her prognosis. She won't go to counseling. She won't talk to a chaplain. Her husband won't do that either. They refuse to have any, quote, negative, end quote, discussion about her diagnosis. But the mother is very open to talking about death, realizing that this is a death diagnosis. And she's asking, how can she lead the conversation to help her daughter discuss this? This is such a tough question. Mm-hmm. I'm going through this with my own family right now. My answer to her is, you can't. You cannot lead that conversation. And as painful as it is, you are going to have to let the patient lead the conversation. You're going to have to meet them where they are. If she doesn't want to face that she's dying, there's nothing you can do but back off and support her the best you can. Dying people, sick people, all people will not listen to family members, but they will listen to strangers. So if you can get a chaplain or a social worker or some other professional to intervene and perhaps try to facilitate that conversation, you're going to have much better luck. But as a family member, the odds are so stacked against you to try to initiate that conversation with somebody who's in that much denial. Karen, your thoughts?
Yeah, and I was going to say, sometimes in the very beginning of an illness, denial serves a purpose. If the diagnosis itself is so traumatizing and overwhelming for the patient, sometimes it's helpful to stay in denial for a while they gradually accept the news and come to terms with it. And so I think there's a place for some denial. But I've seen patients stay in denial throughout their illness, in spite of all the evidence that they're getting closer and closer to death, still wanting one more treatment of chemotherapy and believing this one is going to do it, and I'm definitely going to live. But there does come a point when everyone recognizes, I think it's time to talk about this now. I think it's time to deal with it. Sometimes that point isn't until the last week of life. But again, as you said, there isn't anything we can do to push someone in this process. Each person has to go through it on their own. And for the mother, I mean, how traumatic, how horrible for a mom to have to deal with this and and not be able to talk to her daughter, but please, please talk to other people. Please get counseling, find a best friend or whoever, if you have a faith leader, anyone that you can talk to, because it's very important to keep processing your own grief and your own understanding of what's happening as you're witnessing it, and you're holding space for your daughter, even though you can't have a face-to-face conversation about it.
And speaking of counseling, a really important point that I always try to make is, if you're going to get any kind of counseling about grief or end of life, you need to go to somebody who's specifically trained in that. Your marriage counselor, your family therapist, your psychiatrist, they do not know this world. And it's incredibly important that if you're going to seek any kind of counseling, that you check out the person's training and you ask them, are you specifically trained in grief? In the grief world, we have research that is so new and contemporary, very different than how it was thought of for the last 50 years. But most, your basic marriage and family counselor or social worker is not going to know that stuff if they haven't done specific grief training, which brings me right back to that certification in thanatology from ADEC, because they have incredible material about grief and multicultural understanding. That's another piece. You have to understand where people's cultural references are, religious references. There's so much in that the general psychology population hasn't even touched. So really important to find the right training. And then here's a comment on this. The only thing you can do with somebody who's dying and in denial, or anybody with anything really, is to ask, what do you need right now? Mm-hmm. But with that person in denial, the answer is going to be, I need you to stop talking to me about this. What I need right now is to not look at this. And then you honor that. And you say, okay, let's go take a walk. Let's go shopping. Let's get some pizza. Seriously. I mean, that's really the zen of it, isn't it? To just be in the present time with them.
Exactly. And be wherever that person is able to be, because they're going through their own process.
And that's what we're trained as. That's what we're trained to do as chaplains, is to learn how to meet people where they are. And it's very hard because we all have our agendas. We all think we know what we should do and what the person should do. Mm-hmm. And after many years of chaplain training, we learn that we don't know that. And we let them lead the way.
Exactly.
So with that said, I think we've come to the end of our time. And gosh, I am so grateful to you, Karen, and to all of you. Thank you so much. You're all going to be on our email list now, so you'll get notifications of our next gathering, and you can always send us emails, and you will be getting a link to the recording probably tonight or tomorrow.
Yeah, and I think you're right, Terri. In the future, we probably will try to choose a category or a topic because there's so many questions all over the place, and we didn't even get to the majority of questions. Maybe we can sort them out and go through topic by topic in the future.
We'll definitely do that. We'll get more organized. This was our first attempt, and I think we did pretty damn good.
We didn't even know if we'd get a single question. So.
So we got so many. You can't even believe how many we got. All right, everybody. Thank you. Thank you, Karen. Thank you.
Thank you. Thank you
so much. And we'll see you next time.
Thanks, everyone. Bye.